All right, morning, y'all. I'm so glad we have such a packed house this morning. I'm elated about this fact. So I'm Ashley Bailey Klassen. Today we're going to go over some of the points about buprenorphine. Traditionally, it's been used for opioid use disorder. However, we're now trending much more into the world of pain. So our learning objectives today, I want to discuss the use, like I said, both for opioid use disorder as well for how we're starting to utilize it in pain. I want to go back and review some of the history and the basic pharmacodynamics of why it works on both problems. And then I attempted to dig through some of the best practices and recommendations for the use of buprenorphine. Though, as you'll see at the end, it gets a little confusing, so I'm just going to apologize now. I do have some disclosures. I work with a couple of different spine companies on some products. None of these are medical pharmaceutical companies. They are all device companies. So digging into the historical background, it all gets a little murky when you start getting in the waters. It was buprenorphine itself was discovered in 1965. They got a patent by 1966. Then it was kind of shelved for about 20 years. Nobody really knew what to do with this drug. We had this drug, but no use for it. In 1985, because there was really no interest in it, for some reason it got lumped into the Schedule 5 section, coming from a Schedule 2. When the opioid crisis started to hit and we started having more and more issues with opioid dependence, this drug was then looked into again. In 2002, it came to market under the brand name either Suboxone or Subutex for opioid use disorder, and it was initially FDA approved only for this. Since that time, in various years, it's been FDA approved, so I'm not speaking off-label. It's been FDA approved for both the use of acute and chronic pain, but all of those are very, very different branded names, formulations, as well as routes of administration. So I didn't list them all here, but it's now approved for both. So what is buprenorphine? Had to throw up the lovely biochemical model. You know, we all knew exactly how to build that back in chemistry, right? It is a mixed opioid agonist-antagonist. It is a partial agonist. This is where it gets a little confusing. It's a partial agonist with very, very slow dissociation kinetics. But the actual picture, one, because the opioid receptors themselves are so confusing, and then how this molecule actually binds. The actual picture is really quite complicated. Overall, its action depends on the type of receptor it's binding to. But baseline for opioid use disorder was able to alleviate withdrawal symptoms. It also is able to, because of its partial antagonism, block the effects of other subsequently taken opioids. The neat thing about this, and we'll go into why, most importantly for opioid use disorder, it does have a ceiling effect. Very specific receptors only, though. We'll get more into that. Historically, when it first came out and was used for opioid use disorder, we originally thought it was much better for opioid use disorder than some of the other stuff currently on the market because patients actually maintained a tolerance to opioids while on this medicine instead of straight abstinence. And why that's important is if they do have a relapse episode and continue to take opioids again, they actually have a markedly decreased risk of an accidental death secondary to overdose because they still have some baseline tolerance versus if they are absolutely off of everything, they have no tolerance and are much more likely to have an untoward event during an overdose. This, like I said, is in contrast to straight naltrexone, which is just an antagonist. A lot of times, both Suboxone and Subutex, which I mentioned on the last slide, are actually buprenorphine and naloxone bound together. Buprenorphine and naltrexone bound together. Overall, its side effect profile is markedly better tolerated than methadone, specifically when we start talking about chronic usage. We know some of the cardiac side effects when we have patients on long-term methadone doesn't happen when we have patients on long-term buprenorphine. It is a lot easier to administer as well. Instead of patients having to go in daily, this is something that the FDA has approved for patients to be able to go home with. So they can have a stockpile of this, so to speak, at home and still be considered quite safe with it. So going back to that ceiling effect that I talked about, what's neat about this, and we'll go into the mechanism why on the next couple of slides, the ceiling effect is actually only for the respiratory depression. Maybe a little bit on the GI side effects as well, but mainly for the respiratory depression. So patients can take a significant amount of buprenorphine and not have the sedation and respiratory depression that patients have when they're taking a more traditional opioid. However, when we look at how it binds to the mu receptor specifically, which is more of our pain receptors, its efficacy for pain seems to be matched with all of our other synthetic opioids. So why is this? This is where it gets confusing. So first of all, I want to kind of remind us of all of our different types of opioid receptors, 5 different opioid receptors, and then there is also this G protein independent signaling pathway that can happen as well. On that G protein coupled receptor, this is actually what we call biased agonism. So this involves a very complicated pathway, all downstream effects. But the reason it's important is buprenorphine, and why we think this may be the mechanism of the ceiling effect is when we go and look at these arrestin-3 knockout mice, we've taken away this part of this pathway, so it no longer functions. And all of a sudden, it functions differently. Doesn't no longer function. We changed the mechanism of it. All of a sudden, these mice do not have the respiratory depression or the side effect profile when they're given morphine. So could this be the pathway where the ceiling effect to both the respiratory effect and potentially GI motility happens with buprenorphine? That's what we think for now. It does also bind at the kappa receptor. This is unique in its production of both dysphoria and depression. So buprenorphine is now being looked into as a treatment for refractory depression because it has helped both with depression and anxiety secondary to increases in dopamine. It's also postulated that this is the reason that patients have a alleviation of their emotional component of their pain when placed on buprenorphine. Very similar to ketamine. In ketamine, it's a dissociative anesthetic. There may still be actually since having the pain sensation, but their brain almost doesn't care as much. There is some research that's showing that buprenorphine may be dealing with the active psychoactive portion of pain as well, and so it's not as an emotional response for them. Binding to the delta receptor may reduce the overall addictive profile of needing an opioid because they get a decreased reward benefit when they utilize buprenorphine because of this lack of the synergy at the mu receptor. Pharmacodynamics of this drug, very, very poor oral bioavailability. All first pass effect through the liver, most of it gets rid of. So most of the time we use this in a sublingual form. There is also transdermal, there is a sub-Q injectable depot, but at least in the pain management world, we mainly use the sublingual. It is very, very lipophilic. It crosses the blood-brain barrier very easily. It is hepatically metabolized by the CYP3A4 enzymes. Specifically, it goes into norbuprenorphine. So if you ever need to check if your patients are actually taking this drug adequately, that's what you would actually look for in your urine drug screen, is you have very, very high levels of norbuprenorphine. Its active half-life is about 38 hours. This is going to become important again in another couple of slides when we talk about different dosage regimens of why we utilize it. Excretion, mainly fecal, very, very little in the renal. So, dosing. Like I said, we're using it both for opioid use disorder, but also for pain. This is where it's all kind of, there's so many case studies, there's so many case reports. Recommendations are a little bit all over the place. I actually have up on the slide more of our pain dosing. There are very recommended guidelines for establishing it if you're transitioning somebody for opioid use disorder, but they're sort of similar. You're going to start at the lowest dose and obviously ramp that up as need to. The max in most cases is about 24 milligrams daily. You want to do it in divided dosages. When we're talking about opioid use disorder, because of the half-life of the drug, most commonly it's given in either a single once-a-day dosing or most commonly BID dosing. But when we look at actually how it binds to that mu receptor and blocking up the agonism of that, for pain, patients do a lot better when they take it Q8, or even for acute pain, Q6. So your overall total daily dose is going to be the same. We're just going to break out those dosages and separate them, keep them a little closer separated. When we start talking about our special populations, there is no renally adjusted dose. It is recommended if they are a child 2 class C to decrease their dose by about 50% and continue to monitor. The transdermal or the sub-Q depot is not recommended for these patients just because you're going to get such a high dose at such a high level, we don't really know how to manage it. Pediatric elderly populations, very, very limited data. It is becoming a little more prevalent in the pediatric world. Elderly population, because we'll talk about later, it's a little bit less used. It is a pregnancy category C. Because it does cross the blood-brain barrier, it does cross the placental barrier quite easily. There have been instances of fetal abstinence syndrome noted with patients on this during pregnancy. It does cross into the breast milk as well. So patients that are nursing it is important. But as I mentioned earlier, because of its very, very poor oral bioavailability, it's probably not a big deal. So we see in a lot of our pregnancy patients for OUD, they're still going back to methadone and then coming back on this usually when they're breastfeeding because it's really not affecting the little ones at that point. Contraindications, really just allergy to the drug, and then obviously anybody with an intestinal obstruction, we're not going to give them any sort of opioid. So pretty simple in that one. However, there are some downsides to this use, both of when we're talking about for OUD and for acute or chronic pain. Like I said, not the best for maybe your elderly population because there are some anticholinergic side effects that may cause CNS depression. You can have hypotension, QT prolongation, though much less than methadone. And it can theoretically lower your seizure threshold. However, all of these things have traditionally been very, very well tolerated. So while they're up there, overall, very low risk. While I mentioned in the first slide, this is preferentially used in OUD because of the increased tolerance they still maintain. They're still going to have a decreased tolerance. So anytime you start a patient on buprenorphine for OUD, if they do have a relapse, obviously there is always a risk of accidental death secondary to overdose because their tolerance has just overall decreased. The biggest side effect we see with buprenorphine, and this actually just came out fairly recently, the FDA released a statement regarding this, is actually increased tooth decay. So we talked about that the best way to prescribe this to our patients is sublingually. Well, for some reason, we are seeing significant tooth decay and actually even some bone decay with patients who have been on this chronically. So maybe not the best option long term, at least if we have to continue using it sublingually. Then in my world for pain, a lot of patients are like, why are you putting me on an addiction drug to treat my pain? I get that all the time. And so then I really go through the pharmacodynamics of it and why it actually works better and why it's actually safer for them to be on this med, never mind any of the stigma with the medications. What I don't have on this slide, because honestly, I've seen it get markedly better over the last 3 years, is availability of this drug. About 3 years ago, it was actually super hard to be able to prescribe anybody buprenorphine. None of the pharmacies had it. Only pharmacies that actually tailored to opioid use disorder were the ones that carried it. At least in the state of Texas, where I practiced, you had to have a special DEA waiver. That has since been waived. So actually, access to the drug has gotten markedly easier. But we are at an anesthesia meeting, so I'm supposed to talk about what do we do when this patient shows up in my OR. I hate to tell you, there is no good answer. It is all very, very mixed recommendations. Historically, we thought for minor procedures, just leave them on it, put them on a few other things to help control their pain, and just move on. But what do we do with these major procedures? And I will admit, for pain patients, a lot of them do, sadly, need a repeat large back surgery or something along that nature. So these are going to be surgeries where we expect moderate to severe pain. What are we going to do with them? Historically, the recommendations have always been to taper them off. We're now even seeing spine surgery recommendations to taper opioid use of any type prior to a major surgery so that we have better pain control outcomes on the backside. Buprenorphine or really anything used for OUD, there's a very mixed picture on that. The research shows that if we can markedly decrease that mu receptor being bound up by anything in the 2 weeks before surgery, we're going to have better pain control on the backside. Doesn't matter what the binding agent is, straight opioid or an agonist antagonist. But when we start thinking about buprenorphine for OUD, what about their rate of relapse during that period? We've got a patient on a drug that is keeping them from needing other drugs. And if they go take said other drugs, are they going to overdose? So you have to think about that when you're asking these patients to potentially wean off for 2 weeks. In my pain patients, sometimes I will ask them to wean. I will have a discussion with them. But the biggest thing is, once they get in the OR, hit them with everything else. Multimodal analgesia is the way to go for these guys. I talk to my patients all the time about how many different pain receptors we actually have. This is our world, guys. If we can block up every single one of those other pain receptors, it really doesn't matter if it's a straight opioid or an agonist and antagonist binding up that mu receptor. It's still going to work. So a lot of the newer case reports, a lot of the new multi-analysis are saying actually keep on it. Have patients stay on it. Know that even if they've weaned down because they've been exposed to it, they are probably going to require a higher dose of opioid management, both intra and post-operatively, to be able to control their pain. But like I said, from what's out there right now, super difficult to extrapolate what we need to actually do. So my recommendation, it is definitely going to be a patient-to-patient basis. Really evaluate your patient the day of surgery, figure out where they've been. Was the patient using it just for pain? They're probably a little bit easier to wean. It's safer for them to wean. Were they using it for OUD? In that case, it might be better to keep them on it and deal with the repercussions on the backside because we've got the ability to. What is their baseline chronic pain status coming into this surgery? I talk with both my patients and my surgical colleagues all the time of, look, this patient lives with a baseline pain of X. When you go and do that knee replacement, they're still going to have that baseline pain of X, and we've still got to treat their pain from the knee replacement surgery. So these are just two different things bound up together. Another thing to think about, and then this is missed by a lot of people, is what is their smoking status? We actually do know that nicotine itself sensitizes the pain receptors just like chronic long-term utilization of any opioid. So while they've been on any opioid, even buprenorphine, we're going to upregulate those mu receptors. Nicotine use is actually going to make those mu receptors, the too many numbers that are already there, way more sensitive to any pain. So it's a horrible picture when patients are continuing to smoke as well. So bottom line, really no great consensus on how to treat these patients in the intra and post-op period. It appears the strongest weight is just to be able to keep them on their buprenorphine dose, use multimodal analgesia intra-op and post-operatively, and then know that they're probably going to need a little bit higher opioid requirement on the backside. So in that case, never be afraid to phone a friend. This is where we're here to help step in, whether it's your acute pain team or your chronic pain team that's a little more used to being around the kind of scary doses of opioids. Yeah, I hate them too, don't worry, and it's kind of my job. But give one of us a call. All of us are always ready for recommendations. And with that, I know my talk was a little short, but I will take any questions.
That was a very excellent presentation, Dr. Bailey-Klassen. Dr. Caitlin Pellegrino has been practicing pediatric anesthesia at UNMC, Children's Nebraska, since graduating fellowship in 2018. She's the Associate Program Director of the Pediatric Anesthesiology Fellowship and is committed to resident and fellow education. She has a specific interest in education surrounding disclosure of adverse events and serves as the physician champion of disclosures at Children's Nebraska. Clinically, she also practices pediatric acute pain management and is the head anesthesiologist of the posterior spinal fusion team. In her free time, she enjoys reading, spending time with her husband, and their 3 children. She will be speaking on anesthesia considerations in improving perioperative outcomes for posterior spinal fusion. Please join me in welcoming Dr. Pellegrino.
Good morning. First of all, thank you, Dr. Klassen, for that introduction, and thank you, Dr. Bailey-Klassen, for that excellent presentation on buprenorphine. I hope that I can piggyback off of some of those ideas as we talk about kind of the anesthesia considerations for these surgeries that we see in both our adult and pediatric populations. So first, I have no personal financial disclosures, but my husband does have some industry-funded research with Nevro, which will not be applicable to today's talk. So on our journey today, as we discuss a posterior spinal fusion, we're going to outline the role of the anesthesiologist as part of a multidisciplinary preoperative optimization team for these patients undergoing these surgeries. We're going to review the current and emerging intraoperative anesthetic practices and procedures for these patients. And lastly, we're going to discuss the role of the anesthesiologist as part of the postoperative care team for these patients undergoing posterior spinal fusions. So posterior spinal fusions are actually a relatively commonly performed procedure in the US, with over 300,000 fusions being performed in the adult population annually. And what we know from the projections going forward is that number is only going to increase, particularly in the patients greater than 75, where their projected numbers are expected to double in the next 35 years. In the adult populations, typically 2 to 3 levels are fused, and that fusion is used to treat degenerative disc disease, arthritis, spinal stenosis, spondylolisthesis, and fractures. They're actually relatively common procedures performed in the pediatric and adolescent procedures as well, although less common than adults. Approximately 38,000 posterior spinal fusions are performed annually in the adolescent population to treat idiopathic, neuromuscular, and congenital scoliosis, in addition to some trauma and fractures in there as well. But the difference is in the adolescent and pediatric population, they're typically much larger surgeries where approximately, on average, 12 levels are instrumented and fused. So as we look at these two different spine populations, both the pediatric adolescents and adults, we can see where there's different considerations for both. However, we can take the principles that we use to optimize the patients in both populations and apply them to each other to continually improve the care of our patients. So what is the role of the anesthesiologist as part of this multidisciplinary preoperative team? Well, in our institution, any patient that has significant comorbidities or that we would classify as an ASA 3 or greater is reviewed by our multidisciplinary team prior to surgery scheduling. This ensures that they have all of the necessary pre-optimization, scheduled appointments, clearance by their different subspecialties prior to actually going to the day of surgery, which helps us decrease our rate of day of surgery cancellation for our patients and their families. That helps with overall patient satisfaction. And with our streamlined designated team, it also helps us reduce the time from decision to surgery to actually surgery scheduling and day of surgery. And this kind of multidisciplinary team can be applied to the adult population as well. And while it may be too cumbersome and unrealistic to think that every ASA 3 adult undergoing a posterior spinal fusion could be reviewed, it's important to identify those high-risk patients that could be optimized prior to surgery scheduling. Preoperative optimization is so important because posterior spinal fusions, particularly as we increase the number of levels fused, are high-risk surgeries. And while we cannot change the number of levels that need to be instrumented or the overall surgical time, there are things we can, as anesthesiologists, have a positive impact on, things such as their comorbidity and anesthetic risk. So our multidisciplinary team consists of our orthopedic surgeons, our spine team coordinator, several of our anesthesiologists, pulmonology, nutrition, primary care, and then we also have designated ad hoc members in each of the departments of cardiology, endocrinology, nephrology, and psychology. So if we need to call upon our colleagues for specific needs of different patients, we have point people in each of those divisions to do so. Anesthesiologists are critical members of this team because as perioperative physicians, we can take a look at the specific preoperative comorbidities and also medication lists of each of our patients and try to make sure that those things are optimized and recognize how the interplay of those things will impact their perioperative course both intraoperatively and postoperatively and kind of their recovery. And we can look at that with a broad view. We can kind of get the 30,000-foot view that's not just focused on one specific disease system, one specific organ system, or the surgery itself. We can make sure that any optimization orders or procedures that need to be done, whether it's just beyond the standard labs of echocardiograms, pulmonary function tests, nutrition or frailty assessments can be done and make sure that those are followed up on, but also we can make sure that no unnecessary testing is being done just kind of as a blanket from the primary care providers. Things that the anesthesiologists on my team have successfully advocated for that have impacted The overall outcomes of our patients include advocating for a G button to be placed prior to surgery to make sure that patients have appropriate nutrition and optimal conditions for wound healing. We've advocated for a patient to have a trach placed prior to undergoing their posterior spinal fusion to make sure that they had appropriate airway protection. We've also advocated for patients to be transitioned off of their Depakote in the setting of abnormal platelet function testing and transition to a different seizure prophylaxis with the help of a neurology team. We've also advocated for patients to see a psychologist, either to talk about depression or anorexia or other mental health concerns that would leave them at risk for a kind of rocky postoperative course. And those are all things that anesthesiologists, as part of this multidisciplinary team, have advocated for to help improve overall patient outcomes. In the adult population, this team structure could also be applied to, as Dr. Ashley Bailey-Klassen talked about, optimizing the opioid use for our patients that are taking opioids in the preoperative period. So we know that if patients are taking opioids preoperatively, they are at increased risk of still using opioids 1 year after surgery. So by calling on our local chronic pain physicians to talk about a multimodal analgesic strategy preoperatively, or potentially weaning any patients that can be weaned from their opioids preoperatively, we know we can successfully positively impact their postoperative surgical outcomes as well. This also can go into counseling, just talking about preoperative and perioperative expectations for pain management as well. So while it's important to optimize our patients just to get them to the day of surgery, we also want to talk about the piece of the puzzle that is the intraoperative, kind of the biggest bang for our buck as anesthesiologists. So what are the current and emerging intraoperative practices for posterior spinal fusion? Well, intraoperatively, we know that our goals include hemodynamic stability, both to ensure spinal cord perfusion, optic nerve perfusion in the prone positioning, all of those things that we worry about and we mitigate from a risk standpoint. It's also important that our anesthetic choice aligns with the necessary neuromonitoring to ensure that we have nerve integrity during the procedure and we have appropriate sensory and motor evoke potentials during the anesthetic. And we also know that providing adequate analgesia and kind of initiating that post-operative analgesic process is really important for post-operative success, recovery, and pain control. So just briefly to touch on fluid management, there's also, especially as you increase the number of instrumentation levels, a risk of not only blood loss, but of large volume shifts intraoperatively. So crystalloid choice matters. The group at a Nationwide Children's looked at normal saline versus lactated ringers or Normasol for choice of crystalloid in these procedures and found that those who received normal saline had increased base deficit and also more acidosis both intraoperatively and postoperatively during their course as compared to those children who received lactated ringers or Normasol. Cell Saver is often utilized in these cases to help decrease the risk of allogeneic blood transfusion, but also comes with those similar risks of hypocalcemia and factor reduction, et cetera. So it's important to, even though they're receiving Cell Saver, monitor those things as well. And then lastly, while albumin was once popular for intravascular volume expansion, especially in this type of surgery, it's falling out of favor because of the increased rates of acute kidney injury and also pulmonary complications followed in post-op following the administration of albumin. So there is an ever-growing body of evidence to support all different types of anesthetic choices and techniques for these posterior spinal fusions, and we could probably spend most of the day debating the benefits, alternatives, significance, combinations, choice of whatever you want to during these surgeries, but for the sake of time, we're just going to touch on kind of some of the recent literature on these four kind of major players. So first of all, ketamine. We all love ketamine. It's an excellent adjunct in both its bolus and infusion form for our patients, particularly those who come into the surgeries already with chronic pain. Its NMDA receptor antagonism, again, is especially helpful in patients with chronic pain, but also those that are opioid naive, just to decrease their opioid consumption. Dating back to 2010, Loftus and his team found that in adults with chronic pain, ketamine decreased opioid consumption for 24 hours postoperatively, but also decreased total opioid consumption in the 6 weeks after surgery. On the adolescent side, a 2022 meta-analysis of ketamine use in adolescent spine surgery found very similar findings, and they actually had decreased opioid use for up to 48 hours post-operatively. And those patients had better pain scores as well. For similar reasons, methadone is gaining popularity in spine surgery, particularly in the adult population. Back in 2017, Murphy and his team showed that methadone was safe and effective to decrease overall opioid requirements for up to 24 to 36 hours postoperatively, with some patients even receiving benefit all the way up to 72 hours postoperatively. However, the data in adolescents is a little mixed. Back in 2011, Sharma and his group published that it was incredibly safe, and those adolescent patients receiving methadone had no increased risks associated with methadone and also had decreased opioid consumption. However, that said, in January of just this year, Fons and his group published in Spine that, in pediatric anesthesia, that they really weren't seeing that. They really were seeing some decreased, minimal decreased opioid requirements, but overall no benefit in pain scores. So we're still having a little bit of a mixed bag. The jury's still a little bit out as far as whether in the adolescent populations we're going to see the same benefits from methadone that we see in our adult population as well. There is a large body of evidence in both pediatrics and adult population to support the use of dexmedetomidine for both its opioid-sparing techniques and also its sedation properties intraoperatively. Dating all the way back to 2018, a group from Nationwide Children's showed that when dexmedetomidine is used intraoperatively, the propofol requirements for those patients intraoperatively also decreased. In 2015, an Iranian group compared dexmedetomidine infusion to remifentanil infusion in an otherwise similar anesthetic and found the group that received dexmedetomidine infusion in place of the remifentanil infusion had improved pain scores, improved hemodynamics, and less overall bleeding risk compared to the group that received remifentanil. In 2021, the French group of Julien Marseille and his group looked at the effects of opioid reduction analgesia in pediatric patients undergoing posterior spinal fusion to a standard practice and found that while both groups received some form of opioid, the group that received dexmedetomidine and ketamine had better overall outcomes in the immediate postoperative period, but also had better outcomes at 1 year with a decreased risk of persistent pain in those patients compared to patients that received a more traditional opioid infusion intraoperatively during their surgery. So again, the choices that we're making intraoperatively for our patients with not only their sedation, but also with their analgesic strategies are not only impacting the immediate intraoperative period, not only impacting the immediate postoperative period, the immediate 72 hours postoperatively, but we're also seeing benefits that we can impart on our patients 6 weeks, 6 months, and a year out from surgery. And lastly, I'm going to touch a little bit on dexamethasone. This is kind of a mixed bag. There's no great evidence one way or the other. In 2015, Bednar and his group showed that there was actually very little benefit for dexamethasone use for patients receiving 1 to 2 level fusion. But a 2022 review article by Reed showed that for patients receiving large level fusions, dexamethasone actually helped improve pain scores and actually helped decrease length of stay in the hospital. So helped decrease length of stay, overall impacting kind of recovery outcomes. That said, we know that dexamethasone can come with a somewhat unfavorable side effect profile. There's always that risk for hyperglycemia, and some of our surgeons worry about the potential for bone non-union. But if you look at the literature, one thing that I'll say with dexamethasone compared to some of our analgesics and anesthetics that we've discussed already is that there are wildly varied dosing schedules and strategies in the literature. So I don't think that we have a definitive answer when it comes to dexamethasone. I think that it could provide benefit, but more research needs to be done into appropriate and optimal dosing schedules to actually provide benefit to our patients. And then apart from just overall choice of anesthetic, there's also different anesthetic techniques, particularly regional techniques that we can employ for these patients. Intrathecal opioids are a long-used and well-established practice. However, they're somewhat falling out of favor because the goal of early goal-directed physical therapy and early ambulation is kind of making them fall out of favor. Epidural analgesia is an excellent option for these patients and has been reported to provide at least equivalent pain scores and compared to a traditional opioid-based multimodal analgesic strategy. However, the data also supports for the epidural analgesia patients that they have earlier return of bowel function and also greater patient satisfaction compared to a traditional medication multimodal strategy. That said, surgeons are always concerned about infections of their new hardware that they've just placed, so I know that this is very institution dependent because many surgeons see that epidural catheter as a nidus for infection potentially for their brand new hardware. And lastly, the thing that I'm most excited about to talk about is the use of erector spinae blocks for these surgeries. It has been well demonstrated that for the adult population who are receiving a 1 to 3 level fusion, erector spinae block is an excellent source, an excellent adjunct to a multimodal pain strategy. However, in the pediatric or adolescent population, this has been somewhat questioned just because of the nature of the large surgery, the number of levels instrumented, and the potential volume of local anesthetic that would be required to actually achieve good benefit for the patients while still being within the safety profile. Obviously liposomal bupivacaine can be used to inject in the wound itself, but in just May of this year, the group of Kangor et al. Published in Spine the use of liposomal bupivacaine with an erector spinae block in the adolescent population undergoing adolescent idiopathic scoliosis surgery, and they have really, really promising data which showed improved pain scores, earlier ambulation, and overall decreased length of stay. So this is something that I can't wait to see more of coming out, particularly within the adolescent population for those patients that we, are maybe opioid naive. We want to keep them as opioid spared as possible. I think this is going to become a more and more prevalent adjunct that we're going to be seeing in these types of surgeries, and I'm really excited about it. So now that we've kind of highlighted how not only our preoperative optimization occurs and how the intraoperative anesthetics and techniques that we choose impact patients for the long run, what else can we be doing as anesthesiologists to help with the immediate post-op recovery period, and what role can we play in their pain management? Well, for any patients that stay inpatient, I think that by having these patients' pain managed by an anesthesiologist-run acute pain service can ensure that we optimize that multimodal pain strategy. We know that that's the absolute best thing that we can do for our patients to make sure that they're not only receiving the opioids they need for their acute pain, but also things like gabapentin, clonidine, Valium, NSAIDs, acetaminophen, and any potential regional techniques that can be employed. We can also work to provide that excellent initial pain control, which has been shown to help decrease their risk of persistent pain in the weeks to months after their surgery. We also know that this type of multimodal pain strategy has been shown to help decrease risks outside of just pain with a decreased rate of pulmonary complications such as atelectasis and pneumonia, as well as decreased rates of ileus. And again, that excellent pain control can help overall decrease the length of stay for these patients, because we know with poor pain control and poor participation in physical therapy, those are all barriers to discharge that have to be overcome. And if we have excellent pain control, we have more willingness of our patients to participate in their physical therapy, to get up out of bed, to make their goals, and get home. So as anesthesiologists, we play a vital role in all phases of perioperative patient care. The interplay of engaging from preoperative optimization, utilizing new and exciting evidence-based anesthetic techniques, and also assisting in the postoperative pain control for these patients helps improve their perioperative outcomes and just wanted to thank you all for listening to this talk, and I hope we can continue all to provide excellent care for these patients.
Thank you, Dr. Pellegrino. That was an excellent lecture. Brings back a lot of memories from my fellow years at DC Children's, but that was long, long ago, the 80s. They're really doing things a lot differently. And can I open up the questions? Any questions from the audience? Do we have a microphone? A traveling microphone?
Hello, can you hear me? Thank you for the wonderful talk. The question I have was for all the medications you talk about, like ketamine and Precedex, are there specific recommendations and guidelines on how they infuse these? Are these given as bolus doses? Are they given as infusions? Is it in addition to the REMI and the PROPE in lieu of? Because only reason I'm asking, I know there was a trial from the University of Michigan, I think it was called the podcast trial, and it wasn't specific for spine surgery, but it was just talking about the use of ketamine for post-op pain. And that trial specifically said single bolus doses of ketamine don't help with post-op pain and just worsens delirium. So for these specific surgeries, are there recommendations on how they want these drugs to be administered, infusions, boluses, things like that?
So there are no specific recommendations. Can you hear me?
Yes.
Okay, middle, not a problem. Okay. There are no specific recommendations. I think that some of these practices are institution specific. A lot of the data that I presented showed benefit in both the bolus and infusion for these patients, specifically for the patients that are not opioid naive, that are kind of have a more chronic pain to begin with. That said, I think, again, institution specific, and I think there is benefit in both for this type of surgery, but there are no specific recommendations of what one or the other. I think if you look at dexmedetomidine, the benefit sways towards infusion versus bolus dosing, but I know depending on the institution, both are utilized as well. Hope that answers your question.
I have a couple questions. Dr. Bailey-Klassen, buprenorphine feels like it's going to be an up-and-coming modality for a lot of different avenues, and I've heard of things as far as using them in the intraoperative phase of care for patients for post-tonsillectomy pain or other types of avenues for all of the reasons you've described when trying to take care of people that have any dependence on opioids and having it as that strategy. They've even switched in our own hospital from methadone for neonatal abstinence syndrome to buprenorphine, and they no longer had any of the issues they had with methadone. Have you heard any studies or any onus towards pushing further to using it as a perioperative agent to address all of the things that we keep navigating using short-acting or even the sensitizing agents, even remifentanil? They've shown that one exposure to remi for even a posterior spinal fusion, you can have sensitized mu receptors for even 18 months later from just one exposure. So have you heard anything in the avenues of taking it not just for use disorder or chronic pain?
There are some studies out there for acute pain, not necessarily in the peri-op period as of yet, though there is an IV formulation. It's utilized a lot more inpatient conversion from for abstinence syndrome. But there are some case reports that I found using it more for acute pain issues. I haven't seen many in the peri-op period, and I think there's that concern about it being a partial agonist, or I'm sorry, a partial antagonist, and adding something in the immediate intra-op period that would require an increased opioid load initially, albeit to leave one long term. I agree. I think it's going to be kind of the newest thing on the frontier. I think we will see it coming into the peri-op in the intra-op period as well. There was one case report that I remember seeing of it being used intraoperatively, but it's not heavy use as of yet.
The segue question in there is we in pediatrics sometimes have patients that stay for long periods of time in the ICU or have things like pancreatitis. Caitlin's nodding her head, she knows specifically what I'm referring to. We have amazing patients, like one specifically fell on by a horse, and then they needed to have a lot of different things to stabilize, but then they needed escalating doses of opioids for a prolonged period of time. Even discussing using methadone as a transition to wean them off going home, there seems to be some political and ordering and who maintains after issues. But do you think buprenorphine conversion in the hospital when their acute phase and subacute phase are over could be an option on a multimodal regimen to transition to home?
Oh, completely. And actually, buprenorphine is one of my favorite things for pancreatitis pain. It's especially when we talk about a sublingual application, it's actually a pretty rapid onset within 20 to 30 minutes. So you have these patients with these horrible episodes of pancreatic pain. You can actually get them under control really very quickly. And then the next day, when it's not so bad, they don't have to take it and they're not going to go into withdrawal. So no, for pancreatitis, actually, buprenorphine is one of my very, very favorites. I think transitioning them to something like this in a inpatient setting and transitioning them out would be an amazing protocol to get it initiated. I do utilize a couple inpatient facilities to help my patients who have been on long-term oral opioids to safely transition them to buprenorphine so that we can wean that on the outpatient basis to potentially another pain management modality if we need to, or just to get them onto a safer medication. So no, I think actually starting that in-house would be amazing. Maybe we should look into this.
Any other questions?
I had a quick question for Dr. Pellegrino. I am interested in all the different multimodal stuff that we can do, but something that I noticed that you didn't really talk about was lidocaine infusions. And I wondered if you could comment about whether you have experience with or what your thoughts are on lidocaine infusions for these patients.
So I will tell you again, I think when you look at, so again, a pediatric anesthesiologist here, so take that with it. I don't take care of adults anymore. I think that they can be utilized very well, and there are institution-specific instances where that is part of the protocol because they've had good luck. I just don't utilize them very well in my practice, and they're not as well used or as well described in the adolescent population. So I could have added them, and for the sake of time I didn't, and then I was really fast and I could have had more time. But there's absolutely an application for them. As we look going forward, I think there are better agents that will have a better side effect profile, some of those that I've talked of, and then we can also then utilize safely some regional techniques as well using local anesthetics. So I think there is a place for them, but I think they will fall out of favor as we go forward.
Thank you.
Any other questions from the audience?
So 2 things I want to comment on my co-presenter's PowerPoint that I adored. First of all, as a chronic pain physician, I beg all my anesthesiologists to give any patient with chronic pain that's undergoing, I don't care if it's a toenail removal surgery, please give them ketamine. Please do it, just to bolus dose. It's going to help me out even for those 6 weeks, exactly what you showed. The other thing I really wanted to highlight, you mentioned the use of epidural analgesia for larger surgeries, especially our spine surgeries, but that some of the surgeons are hesitant secondary to infection risk. The reference that you utilize, I actually love because it's a great study that showcases great team interdependence and inner workings. The lead author on that was Scott Blumenthal. And Scott is actually started Texas Back Institute down where I'm a very well-known spine surgeon. So I love the fact that you highlighted a group that came together to take care of our patients better. He's actually one that is huge on the epidural use for spine surgery. So those were my 2 little comments.
Any other questions from the audience? I have a couple of questions for Dr. Pellegrino. In the old days, we used a wake-up test for spinal fusions. especially with scoliosis patients. Now, obviously, we have SSEPs and motor evocs and all of these intraoperative neuromonitoring. There were a lot of preemie graduates in our hospital, and many of them were born with congenital abnormalities, namely scoliosis and some of the other things. Do you find that and at what age do you decide whether it's too early or too late? For instance, with a preemie grad that's got a bad scoliosis and maybe has some respiratory compromise. What age group range are they doing that now?
Are they starting with the spine surgeries?
Yeah.
Yeah. So it's wonderful, depending. So I'm not a surgeon, so I will say that caveat. But there are so many things that people do to try to avoid surgery. So we obviously do the riser and metacasting, things like that. But as in even my practice, which is not short but not long, we've seen increase things like growing rods and things, so we can try to intervene earlier before mature bone age, with trying to prevent progression of their scoliosis, which, that's a separate talk. Obviously, if you're taking care of a 6-year-old for posterior spinal fusion, it's different than a 16-year-old and different considerations. But we see interventions earlier and earlier to try to prevent progression of disease, as opposed to waiting to mature bone age and then having to deal with the repercussions of, however many years of continued bending. Does that answer your question?
Yeah, absolutely.
Yeah.
One question for Dr. Bailey Klassen. Can you speak to the efficacy and usefulness of using the IV form of buprenorphine for our pump patients when they come out and they're having a lot of post-op pain from the incision from the pump implant or the stem implant? The stem's not so bad. You can put them on opioids, obviously, but talk to us a little bit about how you decide whether to use buprenorphine versus some of the other, Robaxin and some of the other IVs.
So one of the things I kind of highlighted or hinted at when I was discussing is the fact that I will take patients who have been on chronic high-dose oral opioids for many, many years, actually place them in an inpatient rehabilitation facility as if they were going in for opioid use disorder, even though they're not utilizing it inappropriately, and get inpatient help to convert them to a buprenorphine. A lot of the patients I do this for are just too medically frail, I feel like, to do it on the outpatient setting. I want them just a little more monitored. Plus, inpatient-wise, they can help with adjuvants like clonidine, things like that, to help mitigate any withdrawal symptoms they do go through. But the reason I'm converting them to a buprenorphine product is it is more like a bridge therapy. Their end result will probably be what Dr. Klassen is hinting at, which would be an intrathecal pump. We have a very heavy intrathecal pump practice. Most of those are utilizing hydromorphone or Dilaudid, but in the intrathecal space, we don't have a lot of the opioid hyperalgesic issues that we do when taken orally. However, pain pumps, intrathecal pain pumps, are well known to be an excellent modality for chronic pain, but in the acute pain picture, they don't work nearly as well. So either immediately after surgery, if one of our pump patients has to undergo a surgery, or just recently we had a wonderfully sweet pump patient fall and break her arm and have to have an ORF of her arm. So what do we do for patients in that period? Sometimes we can turn the pump off and just let them take care of any acute pain as you normally would. But other times we will actually place them on a buprenorphine product with the intrathecal pump still running. The reason it's safe to do that is exactly what I talked about with the ceiling effect of the respiratory depression. While respiratory depression from intrathecal use of opioid in the outpatient setting is very, very, very rare, especially in our practice because we're doing microdosing. So we're talking about micrograms instead of using milligrams, which is a very historical way of dosing intrathecal pumps. The risk is still there. And so none of my patients, my cancer patients included, are outpatient therapy with an intrathecal pump and oral opioids. That's just not something that we do. But like this patient who has a broken arm at the moment and just had surgery, her pump is continuing to run because it controls her widespread chronic pain. secondary to a scoliosis surgery, actually, very, very well. But now with this external ORIF of her arm, she's been in acute pain. So we started her on a buprenorphine product to be able to control the acute pain very, very well, and leave her chronic pain relatively intact in its care. We will use the IV form in the hospital when we can, obviously for our acute postoperative patients. But I also use a lot of Exparel on those too, so they don't need it very much.
Thank you. Yeah.
I have a question for Dr. Pellegrino. One of the controversial things that we've encountered is when you do a scoliosis correction, some of the most discomfort is generated from muscle spasms. And while we may have different practices in the pediatric phase versus the adult phase, where some institutions will not give concurrent benzodiazepines as they give opioids, even as you give it and rapidly de-escalate in the postoperative period. What are your thoughts on the efficacy and the use of different types of muscle relaxants, especially in the first 72 hours with the patients that you're seeing?
I love this question. So they're actually my favorite agent to use out of any of the opioids, NSAIDs, et cetera, in the immediate postoperative period for these spine patients. So we do concurrently at our institution give both opioids and benzodiazepines as long as they're not given within 1 hour of each other. But I think a scheduled muscle relaxant, whether it's, we use Valium at our institution, but whether it's Robaxin, whatever you have available at your institution, gets you more benefit, particularly in the 48 to 72 hour post-op range than any opioids or any other agent you can provide. And I explain that to parents where it's like, it's a bit, you're used to being in this position and you stretch that muscle and now it wants to cramp back to where it was and it cannot. So I think that of any of the agents that we use in the immediate postoperative period, that gets us the most, as I tell parents, bang for our buck, where yes, it's, we need to treat the actual, incisional pain and things like that, whether it be with a block or an epidural or opioids, et cetera. But I think that especially going home, I will tell patients, try your muscle relaxant first. If you can't sleep or if you're having pain, try that first. And I often advise parents and our orthopedic surgery team in a discharge strategy. We try to be opioid conscious, and we often we recommend, now whether they follow our recommendations, hard to say, but only a certain amount of doses of opioid to be prescribed to patients. We really try to get against the 60 pills of oxycodone. We say they may need 10 doses, and to have our orthopedic surgeons only really prescribe those 10 doses. I will often recommend a greater percentage or a greater number of doses of our muscle relaxants, of our Valium, et cetera, than our opioid, because I think that they're the best adjunct that we can use in the immediate postoperative period from these surgeries.
Great. I've got one other question for Dr. Pellegrino. For congenital heart patients, as they grow, obviously, if they also have they've had an ASD, a VSD, a repaired TET, something like that, how is there a difference in the way you manage them and in terms of expectant time that you're going to have to keep them in the hospital? And do they do fairly well in the perioperative period?
Absolutely. So I will say that for our congenital hearts for non-congenital surgery, we often in these larger surgeries will either consult or work very closely with our pediatric cardiac anesthesiologists to talk about a strategy. We have, depending on the level of congenital heart disease, if you listened yesterday, there is a wide variety. That you have the patients that once had congenital heart disease and are fully repaired, and they have specific considerations to those that are still, living with saturations in the 80s because they have a Fontan or whatever the case may be. We don't necessarily treat them differently from a pain management strategy, but they do have specific considerations when it comes to intraoperative fluid requirements, intraoperative pressor requirements, which we could certainly give an entire other talk on for those patients undergoing large surgeries like this with expected fluid shifts. We see a little bit of increased length of stay and recovery for them, but from a pain standpoint, they tend to do very well. They're usually, they're not opioid naive per se. They've had major cardiac surgeries, but they tend to be off prior and are no different from a pain management standpoint than any of our other patients.
The blood loss seems to be a big thing. Orthopedic surgeons, at least in my experience, tend to lose a little more blood than the neurospine guys. It depends on where you are. But in your replacement, do you find that do you ever use whole blood, or it's just components?
At our institution, we don't have whole blood, so it's
Yeah.
just components.
Okay.
But we're checking very often, especially if we are anticipating blood loss. So actually, the group that we see the highest risk of blood loss in for our scoliosis patients are our cerebral palsy kids that have neuromuscular scoliosis, more than our muscular dystrophy kids, more than any other of our neuromuscular scoliosis kids. Those patients tend to have the greatest risk of bleeding. I don't have a reason for why. If you look at the literature, it supports that, but anecdotally as well. So we don't have whole blood, so we just use components. But I would totally think that if your institution has whole blood, utilizing that strategy would be excellent.
Great. Thank you all for your questions. We have time for a short break. I want to thank Doctors Ashley Bailey Klassen and Kate. Is it Kate? No. Yeah, Caitlin. Close. Pellegrino for great lectures and great answers to our questions. Thank you very much.